Good evening to all of you. I bring greetings to you from the Ganga team, and I hope that you and all your family members are good and safe in these challenging times. I think this small virus has locked all of us down. But on a principle, education and life cannot be locked down completely. So I'm quite happy that the Indian Orthopaedic Association, along with Janssen, has taken this excellent step of continuing the education. And we at Ganga are really happy and proud and feel privileged to be a part of this. So I would also like to start off for OrthoTV to join in this initiative so that the reach would really be great. Now, the idea of today's topic is that we had, we all know that a clinician is only as strong as his diagnosis. And in this, while it is true for any specialty in medicine, orthopedic surgery actually relies heavily on imaging. And that's the reason that while our first seminar a few weeks ago was on clinical examination, we thought that this should emphasize and concentrate on orthopedic radiology. Now, to complete this, we have excellent faculty today. And we have Dr. Venkatadass, who is the consultant and head of the Pediatric Orthopedic Department in Ganga Hospital, Coimbatore. He has a passion for pediatric orthopedics and had his training inland with Dr. Ashok Johari and Virsha Madhuri, and then did his postdoctoral fellowship in limb reconstruction in the MGR Medical University, Chennai, and then had an advanced fellowship in pediatric and adolescent hip disorders in San Diego in USA. He's a very active member of POSI and has a keen interest on research, academics, and publication, and has authored several international publications, and also was the organizing secretary for POSICON 2020. We also have Dr. Pushpa, who is the consultant head of the radiology department in Ganga Hospital. She has a passion for musculoskeletal radiology. She had her specialty training in Stanmore, UK, and then did her fellowship in the Royal College of Radiology. She is an expert in special interest and is very keen on guided interventional radiology in MSK, and is also the co-PI of a major DBT research project. And to her credit, she has been an organizing member and faculty for many radiological meetings. Following the two talks, I would also be talking on evaluation of spine radiographs. And after these three talks, we will have a question and answer session for 15 minutes. Now, between the talks and the question and answer session, we will have a short intermission for perhaps 1 or 2 minutes so that we will have a feedback form filled from you so that we will know how this has benefited you and what can become better. Now, we'll go on straight to the topics, and I would request Dr. Pushpa to go ahead with another very important topic for postgraduates, radiology of bone tumors. This is a topic that gets covered in your theory, it gets covered in your clinical examinations. It's a very favorite ASCII topic. And also in the afternoons when you go in for radiology, at least for sure you will have 2 or 3 tumors put onto you for assessment. So this is an interesting topic, and thank you, Pushpa, for sharing your time. And she will talk to us on how to approach imaging of bone tumors.
Thank you, sir. I was only hoping that Venkatadass sir will cover osteoblastoma for me. But anyways, we will start with the approach to imaging of bone tumors. So I'll not be covering in detail of each and every tumor. I'll be just giving you an approach, how to approach bone tumors as a whole. So having said that, radiology forms at least 80% contribution to the diagnosis of the bone tumors. Here you can see there are two lesions. One is the osteosarcoma of the proximal femur, and the one is the myositis ossificans involving the left iliac bone. So if you biopsy these two lesions and send to the pathologist, they will not be sure whether it is a osteoid forming bone lesion or whether it is a myositis ossificans. So they heavily rely on radiological as well as clinical features. But radiology, as I said, plays more than 80% role in diagnosing the bone tumors. So we have to be very sure about the radiological diagnosis. So as we all know, we have primary bone tumors, secondary bone tumors, and bone tumors forms hardly 0.2% of tumor burden in humans. And primary malignant bone tumor makes only 1% of all malignant tumors. Commonest bone tumor is secondaries, whereas commonest primary bone tumor is multiple myeloma, second only to osteosarcoma. So whenever you have an X-ray with you and there is a bone tumor, you have to follow some rules to come to a firm diagnosis or at least a decent differential diagnosis. So what are all these 8 rules? One is you have to know the age, then location, size, zone of transition, pattern of bone destruction, periosteal reaction. And also you have to know what is the matrix within the tumor and whether it is polyostotic or monostotic. Coming to the most important rule, one is that is age of the patient. So this diagram gives a very nice picture about what to expect in the different age groups. So when you have an X-ray, first you look at the bones to see whether it is skeletally mature bone or skeletally immature bone. So that gives most of your answers. And also, if the patient is with you, try to ask what is the age, what is the clinical features, and what is the presentation of the patient. This also contributes to about 10% of your answers. So here in this picture, you can see that all the benign lesions like simple bone cyst, aneurysmal bone cyst, osteoid osteoma, and Ewing's, eosinophilic granuloma, all this come under the age group of 10 to 30 years. And only Ewing sarcoma and osteosarcomas are seen in this age group. Whereas most of the malignant lesions like metastasis, myeloma, chondrosarcoma, and periosteal osteosarcomas, all these are above 30 years of age group. So it is very, very important to know the age of the patient. Second important thing is to know the location, which is very, very crucial. Like many bone tumors have predilection for different bone in the skeleton. So if you see here in this picture, skull has predilection for metastasis and myeloma, whereas adamantinoma and dentigenesis are more commonly seen in the mandible. Whereas small bones of the hand, the flat bones, they have predilection for enchondromas, and GCT and Ewing's granulomas are seen in the distal radius. When you see around the bones of the knee and shoulder joint, almost all bone tumors are seen in these areas. So you should have a background knowledge about what bone tumors has a predilection for certain site of in the axial skeleton. After combining age and location, you will be able to solve about 30% of your problem. So you should know the age of the patient and you should have the background knowledge about where the location of the tumor is going to be. So here you see 2 pictures here. One is where the bone is skeletally immature. So the physis is open still. So this is a skeletally immature bone. The other picture is where the epiphysis is fused. So you have different tumors in different age group as we already saw. And then you have different location for each of these tumors. So you have, if the growth plate is not fused and the bone is skeletally immature, you see in the epiphysis you have only chondroblastoma and chondrosarcoma. Once the epiphysis is fused, in the subarticular region you have germ cell tumor and malignant fibrous histiocytoma. So like this, depending on the age of the patient and depending on the location, you have different tumors. You can see osteosarcoma in a skeletally immature bone is having predilection towards the actively growing bone, that is metadiaphysis. Whereas a marrow infiltrating lesion like Ewing sarcoma are seen in the central medullary cavity. And again, the benign lesions like fibrous dysplasia, simple bone cyst, and even enchondromas are seen in the central aspect of the immature bone. So you should know all these predilection for the bone tumors. Then you will have, along with the age of the patient, then you will have 30 to 40% of your problem solved in diagnosing the bone tumors. So have a background knowledge about the age and location of the tumors. This is another nice pictorial depiction of how the tumors can have predilection for the different sides of the tumor. So simple bone cyst is in the central aspect, but it is near the metadiaphysis, whereas enchondroma is little away from the end of the bone. Fibrous dysplasia is almost in the diaphysis, although it can extend up to the metaphysis. When you see non-ossifying fibroma, aneurysmal bone cyst, and chondromyxoid fibroma, all of these, and fibrous cortical defect, all of these are mainly involving the eccentric area of the bone, and they are also in the either metaphysis or metadiaphyseal region. Whereas giant cell tumor is exactly under the subarticular surface, and it is also seen in the skeletally mature bone. And there are few exceptions where certain tumors have very much focused appearance, wherein like osteofibrous dysplasia and adimantinoma, they're almost involving mainly the anterior cortex of the tibia. Especially in osteofibrous dysplasia, these are seen in the younger age group, and adimantinoma is seen in the older age group, and they have propensity to involve soft tissue as well as medullary cavity. So these can be easily diagnosed based on the knowledge of where they are commonly found. Parosteal osteosarcoma is another example where you can see it is predominantly localized to the posterior aspect of the distal end of the femur, and then you can see it is just abutting the cortex without involving the medullary cavity. Next important thing is size of the lesion. More than 5 centimeters, any lesion is considered to be malignant. However, some of the lesions like fibrous dysplasia, Paget's disease, sometimes even simple bone cyst can grow more than 5 centimeters. The next thing is osteoid-osteoma versus osteoblastoma. Here, I am not going to tell the details about how to diagnose all these lesions, but I'm just giving you a proper overview of how to differentiate between the lesions. So this is, you can see there is a osteoid osteoma on the right side, where you can see a small nidus, which is lucency within a sclerotic lesion, which is cortically based in the diaphysis of the femur. So this lucency within the sclerotic lesion is less than 1.5 centimeters. Whereas in osteoblastoma, which is on the left side, you can see a large nidus, which is more than 1.5 centimeters. This is how, depending on the size, you are going to differentiate certain tumors. As before I told, fibrous dysplasia can involve more than one bones. As you can see here, iliac bone as well as the femur, left femur is extensively involved, which shows gross expansion as well as ground glass matrix. So they can use, they can be very large in spite of being benign, and they can involve multiple bones. The next thing to concentrate is what the tumor is doing to the bone. That is called a zone of transition of the lesion. So here you have good two examples where it shows a narrow zone of transition. What means the narrow zone of transition is like you can clearly draw a line between the tumor and the normal bone. If you can do that, then it says that it is a narrow zone of transition. If you see a bright line around that is a sclerotic border around the tumor, then it is a narrow zone of sclerotic border. In case of skeletally immature bone, like in this non-ossifying fibroma, this you can see there is a proximal tibial lesion, cortically based, in a skeletally immature bone. It shows a nice soap bubble appearance, mild expansion, and then it has a very narrow zone of transition. It means to say that you can draw a clear line between the tumor and the normal bone, as well as there is a thick sclerotic rim around it, a fine sclerotic rim around the lesion. This itself says that this is a very benign tumor, and it is a 100% non-ossifying fibroma. So looking at the tumor, looking at the zone of transition also, you can tell whether it is aggressive or a non-aggressive, especially in a skeletally immature bone. The second is unicameral bone cyst, second example, wherein which you can still draw a clear-cut line between the normal and abnormal bone, and you can see a nice central lytic lesion. But there is no sclerotic border. It has a distinct border, but it doesn't have a sclerotic border. So this is also called as narrow zone of transition with distinct border, which is typical of aneurysmal bone cyst and unicameral bone cyst. However, we should remember that if the patient's age is more than 40 years of age group, then Metastasis and myeloma can also look like what we are seeing like in unicameral bone cyst in a younger age group. So you should remember this, that in a younger age group, narrow zone of transition most of the time and with a sclerotic border definitely means that it is a benign lesion. And here is an example where you can't make out any distinct border between a normal bone and an abnormal bone. So this is one first example is osteosarcoma. The second examples which I have put is infection in eosinophilic granuloma, just to tell that even infection in eosinophilic granuloma, in spite of being a benign lesion, can show aggressive behavior in the form of narrow zone of wide zone of transition. So whenever you have a wide zone of transition or an indistinct zone of transition, we should always think of osteosarcoma, but infection and eosinophilic granuloma should be ruled out clinically and with other parameters. The fifth important thing is pattern of bone destruction. So when you have a large map-like area of bone destruction, then you call it as the geographic bone destruction. And sometimes you have moth-eaten type of destruction, wherein which you see multiple lytic lesions within the bone tumor, and they will be of variable sizes. That is called moth-eaten destruction. Permeative destruction is mainly marrow-infiltrative disease like Ewing sarcoma, leukemia, and myeloma, wherein which you see tiny areas of bone destruction which will be of equal size. So almost moth-eaten destruction and permeative destruction are indicative of malignancy. So this is type 1A type of geographic bone destruction, wherein which you see a sclerotic rim. Again, you can see unicameral bone cyst sometimes comes with a sclerotic borders, a lytic lesion, large lytic lesion, and then it has a geographic pattern. And fibrous dysplasia shows a ground glass matrix with a thick rim of sclerosis. So most of the lesions like unicameral bone cyst, non-ossifying fibroma, enchondroma, chondromyxoid fibroma, chondroblastoma, fibrous dysplasia, these all find, you can see that they have a sclerotic rim, narrow zone of transition in spite of having a geographical type of bone destruction. These all come under the benign category. The second thing is the giant cell tumor. So this is mildly aggressive, locally aggressive lesion, wherein which you see a geographic type of bone destruction, but the borders are not extensively distinct, like in what we saw in fibrous dysplasia or in case of unicameral bone cyst. This is type 1B. And the malignant type of geographic bone destruction is like you have a large bone destruction, as you've seen in this left iliac bone, large geographic bone destruction, but the borders are the zone of transition is completely lost. So there is an indistinct zone of transition with geographic destruction. So this is seen in 1C type of lesions, definitely malignant. So this was plasmacytoma. This type of bone destruction can be seen in giant cell tumors, plasmacytoma, multiple myeloma, as well as metastasis, and sometimes even in case of renal cell metastasis and thyroid metastasis. All this can give rise to expansile geographic type of destruction without any distinct borders. This is an example of permeative bone destruction. As I said, this can be seen in Ewing's, lymphoma, leukemia. This is a moth-eaten type of bone destruction. This is a case of osteosarcoma where you can see a lot of lytic areas of different sizes. This is also a malignant type of lesion. So I'll come to how to do the histological diagnosis. I'm just giving an overview to call what is malignant and what is not malignant here. So these are multiple punched out lesion. If it is a younger child, then we can still think of either neuroblastoma metastasis if it is less than 1 year. So little older child, you can think of Langerhans histiocytosis. The skeletally mature individual, more than 40-50 years, you can see of multiple myeloma. Next one is how the bone is reacting to the tumor. So you have to know the periosteal reaction, soft tissue involvement. This is the sixth rule. You should always look for the periosteal reaction and also soft tissue extension to call whether it is benign or malignant. So you have two types of periosteal reactions. One is uninterrupted and interrupted. Interrupted is likely to be locally aggressive lesion, whereas uninterrupted is likely to be benign. So in uninterrupted, we have solid petrous type and solid longitudinal and undulated, whereas in interrupted, we have sunburst type and lamellated type and Codman's triangle. So let's see each one of it. So in case of lamellated and multi-layered lamellated periosteal reaction, what happens is the bone tumor starts growing and the bone tries to contain it by forming a new bone formation. So whenever there are the periods interval between where the bone can actually contain the tumor by forming a new bone formation, and the periods where it cannot. So depending on that, you have multiple layers of fine periosteal reaction called as lamellated reaction. So this is particularly seen in Ewing sarcoma and osteomyelitis. Again and again, I'm pointing out osteomyelitis because it is a great mimicker of Ewing's tumor. In spite of being a benign lesion, it can present as aggressive and clinical features can be very confusing. So you have to do MRI or you have to do blood investigations and clinical investigation, sometimes even biopsy, to rule out osteomyelitis and confirm Ewing's tumor. I will tell how MRI helps in these situations as well later. And then there is a second type of malignant type of periosteal reaction. This is a sunburst type of periosteal reaction where the new bone is formed perpendicular to the affected bone. This is because new bone is deposited along the neovascularization or fibers of surface. So this will result in sunburst type of periosteal reaction, which is also very malignant type of periosteal reaction seen in Ewing sarcoma and osteosarcoma. The third uninterrupted type of periosteal reaction, which is very important, is Codman's triangle. So here what happens is the soft tissue tumor actually bursts out of the bone, and while doing so, it will strip part of the periosteum. When it strips the part of the periosteal reaction, what forms around the bone tumor and soft tissue component will look like a triangle. So this is called Codman's triangle, which is also seen in aggressive bone tumors with extensive soft tissue tumors and rapidly growing soft tissue component. Example, osteosarcoma. So as I said, uninterrupted periosteal reaction, that is solid buttress of periosteal reaction, you can see in osteoid osteoma and chronic osteomyelitis. Like in this case, this is an osteoid osteoma where there is a thick buttress of periosteal reaction and central small nidus in a cortically based lesion of the diaphysis of the tibia. And then you have a nice laminated single layered periosteal reaction, which can be seen in hypertrophic pulmonary osteoarthropathy, thyroid arthropathy, and all these benign lesions. So you should also remember that if the tumors have no periosteal reaction at all, there are few tumors which can have no periosteal reaction at all. So these are also called as leave me alone lesions. Again, these can be non-ossifying fibroma, intraosseous lipoma, fibrous dysplasia, and chondromas. These are like leave me alone lesions. I don't need any attention whatsoever. I don't do any harm to the patient. So you need not do anything for these patients unless they undergo pathological fracture and develop. These will not develop any periosteal reaction unless they have fracture. Coming to the next most important thing is to know whether the lesion can be multiple or single. So we know lots of benign lesions can be multiple and few of the malignant lesions can be multiple, like myeloma, metastasis, lymphoma can be multiple. Here are a few examples, like hand is showing multiple enchondromas. There are a lot of calcifications within the soft tissues, which are nothing but phlebolymph in the hemangioma. So this is a case of multiple enchondromas and multiple hemangiomas in the soft tissue. It's a Mephosis syndrome. Next is hereditary exostosis, wherein you can see there is lots of expansion of the head and neck junction of the bilateral femurs, and this is because of the sessile enchondromas there. And then you can see a large chondroid lesion arising from the right iliac bone along with extensive soft tissue component. This was a hereditary exostosis patient who developed later on had one of the lesion transforming into chondrosarcoma. So far what we discussed is how to differentiate malignant from benign lesion. So you have a well-defined lesion with a sclerotic border, no soft tissue mass, very solid single-layered periosteal reaction. Then you definitely tell it is a benign lesion. Whereas if it is a malignant lesion, you have a moth-eaten or permeative bone destruction or a large geographic type of bone destruction with a narrow zone, wide zone of transition and interrupted periosteal reaction, you are calling it as malignant lesion. So what is the next clue? Next clue is you have to look into the tumor matrix. Once you look into the tumor matrix, you will be definitely able to tell for most of the time what is the type of the histology within it. So you have at least 4 types of mineralization or 2 types of mineralization, that is osteoblastic mineralization and chondrite type of mineralization. And sometimes you don't see any mineralization at all, and then you have a ground glass appearance. Let's see each of these examples to differentiate different lesions in different categories. So this is fibrous dysplasia. Again, I'm stressing that it is involving a long bone, and it is involving the diaphyseal bone first, and then it extends up to on the either side of the bone. And if you see the matrix, there is a ground glass opacity. Zone of transition is narrow, and there is no periosteal reaction. So this is 100% fibrous dysplasia. Again, we have osteoblastic mineralization. In benign conditions, you can see osteoma, osteoblastoma, all have a chalky type of bone mineralization, which is called as osteoblastic mineralization. These are the benign lesion. Whereas in case of parosteal osteosarcoma, you can have a thick cloud-like calcification, where this is easy to tell that this is a aggressive lesion. When there is bone destruction is of aggressive pattern and matrix mineralization is of osteoid type, then you can easily call it as osteosarcoma. So this is how you tell the diagnosis of the histological diagnosis as well, by just looking at the pattern of destruction. First you decide whether it is malignant type or a benign type of bone destruction. Then you look at the matrix. If it is osteoid matrix, it is definitely going to be either a benign osteoid lesion or a malignant osteoid lesion. So malignant will be either depending on the location, parosteal osteosarcoma or osteosarcoma. The next type of mineralization is chondrite type of osteoid mineralization. So first you see the first picture, what you're seeing is there is a nice lytic well-defined lesion in the skeletally immature bone within the epiphysis. So when you see the matrix, you can see that it is a popcorn type of matrix mineralization. This is definitely chondroblastoma. You can't think anything else in the epiphyseal aspect, except for another DD would be clear cell chondrosarcoma. Then enchondroma, small flat bones with popcorn type of calcification, mild expansion. This goes in favor of enchondromas. Osteochondroma. Osteochondroma is also very easy to tell it is a osteochondroma, where it starts from the metaphyseal region, grows towards the diaphysis, and the cortex is continuous with the cortex of the main bone, and the medullary cavity of the lesion is continuous with the medullary cavity of the bone lesion. At the tip of the osteochondroma, you can see a chondrite type of mineralization. So these are very characteristic of benign type of chondroid lesions, whereas this one is showing like a previous picture, where you can see within the soft tissue component and within the lesion, you can see there are ring and arc type of matrix mineralization. This is very typical for chondroid lesion because it is extensive, because it is quite large. This is malignant transformation of osteochondroma. These are the examples where we are not seeing any mineralization at all. So first picture, what do we think? There is a lytic bone lesion. There is a clear-cut zone of distinction. There is no periosteal reaction, no soft tissue component, which is a skeletally immature bone, and it is almost reaching the metaphysis. So this is a unicameral bone cyst. What is giving a best clue here is it has undergone a pathological fracture, and then you can see a small bone fragment within it, which is called fallen fragment sign. This is very typical of simple bone cyst. Next lesion also looks almost similar to unicameral bone cyst, which I showed which we saw previously. But what is the difference here? So here you can see there is mild expansion of the bone. Here also the lesion is in the same place as in the unicameral bone cyst. Here also the skeletal is immature. But what you are seeing is it is mildly expansile. It is little bit eccentrically located as compared to simple bone cyst. You can see a lot of trabeculations. And if it was more expansile, it would have developed some type of benign type of periosteal reaction as well. So this is an aneurysmal bone cyst. When you do MRI, you can see multiple fluid levels also. I'll be showing such a lesion next in the upcoming slides. And the third lesion, what we are seeing is showing a soap-bubble appearance, clear-cut zone of transition, that is a narrow zone, sclerotic zone of transition, cortically based in an immature bone of the metadiaphyseal region of the tibia. This is non-ossifying fibroma. Fibrous dysplasia, we have already discussed fibrous dysplasia. So there is no obvious mineralization in all these tumors. And also we have also already gone through GCT and plasmacytoma. These are the tumors which need not have any matrix mineralization, but depending on the type of, depending on the age, location, and type of bone destruction, we are coming with a diagnosis. So we now categorized the bone lesions. We followed all the 8 rules. Now what? So now what we have to do is we have to divide all these lesions into 5 categories of bone tumors. This will help us to further manage the bone tumors. So what are these 5 categories? First thing is, already we know, leave me alone lesion. This requires no further imaging, no further attention towards it. So we have already seen few. And few to add is bone island, where you can see a small sclerotic lesion with speculated borders. And these can be incidentally picked up when we are imaging for some other thing. So these are just leave me alone lesions. Second thing is malorostosis, unless it is causing some type of compression somewhere. And if you see some dense calcification which has a candle wax dipping type of pattern, this is like you have to leave it alone. You need not do anything. The third one is cortical desmoid, where this is just because there is a cortical defect in the posteromedial aspect of the distal femur. This is only because of repetitive stress from the gastrocnemius, and you need not do anything for these lesions. So there is no intervention required for all these lesions. Then there is another category where again the patient is asymptomatic, and we are almost certainly sure that these are benign, but these need to be followed up. Like osteochondroma, as I said, they can have a cartilage cap, they can grow more than 1.5 centimeters, they can have sarcomatous transformation. So you need to follow them up, but they are safe to be followed up. Like you need not immediately do any intervention for these lesions. The second thing is Paget's disease, where you can see there is a bone expansion, there is a lot of sclerosis, and then there is bowing of the bone, trabeculations are thickened. This is definitely very classical of Paget's disease, but you need not do anything unless there is a fracture, or you have to follow them up to look for any osteosarcoma transformation only. So you need not do immediately anything. The third category is also a benign lesion, but the patient might be symptomatic in this lesion. As we said, there is a fracture through a simple bone cyst, there is a fallen fragment sign. You need to do something because patient is symptomatic. But looking at an X-ray, you are already 100% sure that it is a benign disease, and you know the lesion very well, what is the extent of involvement. The second lesion, again, it is a skeletally mature bone, there is a osteolytic lesion in the subchondral region. So this also, we know that it is a giant cell tumor, and you need not do anything else in the sense that you need not do extra imaging for this, for the confirmation. Then the fourth category comes in, where you are very uncertain about the diagnosis. Like it has a mixed aggressive and less aggressive features. So it has a mixture of both benign and malignant. So you need to carefully assess it further. So you have to look in for further assessment. You can't make the diagnosis entirely based on the radiographs. So you have a radiograph here where you can see osteochondroma, and you also have a very atypical type of it is a typical type of chondroid mineralization around the surface of the osteochondroma, but you are not sure what is the thickness of the cartilage here. So you do the next modality, that is a CT scan. Unfortunately, I don't have MRA for the same patient, but we could definitely make out that the cartilage thickness here was quite more, and it was more than 1.5 centimeters. And there was a typical appearance of ring and arc calcification. So we could definitely tell that this lesion is shows malignant transformation. So this is the fourth category. Fifth category is obviously malignant. Like what we saw, osteosarcoma and plasmacytoma, all these things, they will definitely need further workup for the diagnosis and staging. So last two categories, what we discussed, will definitely need further imaging. So coming to the role of cross-sectional imaging, so we can do CT scan and MRI, and some cases we have to do both CT scan and MRI. So both of these are mainly to see the extent of the lesion, to do the staging, and sometimes in CT scan for the doing the guided biopsy, and in case of osteoid-osteoma, CT scan can be used for radiofrequency ablation. So these are the role of different imaging modalities. When you more and more we are seeing imaging of the bone tumors using MRI. This is mainly in the cases where the patient is having persistent localized symptoms, but we are not seeing anything in the radiograph. This is simply because before 30 to 50% of loss of mineralization is there, we can't see any lytic lesion in the bone. So these are some examples where this is a case of giant cell tumor where the lesion was very subtle. We couldn't make out the lesion very definitively. So then we did the CT scan, and when we did the MRI, the lesion was very nicely visualized. So here the role of MRI and CT we can see. And this was the HIV patient, and then she also presented with lot of hip joint pain. But X-ray was not very conclusive, nor even suspicious. But when we did MRI, we can see there are huge involvement of iliac bone, and on the either side of the iliac bone there is a large soft tissue mass. This was a case of lymphoma. And the next thing is to know the exact extent of the bone tumor and the soft tissue component. In X-ray, hardly we can tell that this is a case of osteosarcoma. We can just tell this is a case of osteosarcoma. There is extensive bone destruction. There is extensive soft tissue looking at the X-ray. But to the what extent the bone is involved, by looking at the X-ray, you can tell that it is involving up to the proximal third. But if you see in the MRI, where the arrow is marking, this is a T1 weighted coronal image, you can see the marrow is involved as long as up to the greater trochanter, that is the intertrochanteric region. So you can clearly demarcate the normal bone and abnormal bone using the MRI. And the soft tissue component also is quite huge, and the extent and neurovascular involvement can be easily made out using cross-sectional imaging. The same tumor had multiple cannon wall metastases in the lung as well. And this is another lesion which was showing there was extensive soft tissue and there was involvement of the popliteal artery. So this plays a major role. And the arrowheads are showing that it is not involving the sciatic nerve, that is tibial nerve and common peroneal nerve divisions, where it is not involving, and it is just compressing the popliteal vein, but it is definitely involving the popliteal artery. This is a major role of MRI, where it can clearly tell you whether the neurovascular bundle is involved or not. Some of the marrow bone lesions again are very well seen using the MRI. So here again you can see there is a small bone destruction, but a large soft tissue component. This is typical of small cell tumors like Ewing's tumors, lymphomas, and leukemias. All these small tumors will result in extensive soft tissue component before they show any bone lesion. So remember, if there is a small bone lesion, but on either side, if there is a large soft tissue component, then it is definitely some sort of round cell tumor. Sometimes you want to know a firm diagnosis using MRI. So here is a lesion, and looking at this, I actually thought it is just an enchondroma without any tumor matrix. There is no typical of chondroid matrix which we see in flat bones with enchondromas. But I was totally wrong. When I saw MRI, it showed multiple fluid levels. So the diagnosis of aneurysmal bone cyst was made in this case. So this is a nice example where MRI also gives some amount of histological diagnosis. This was a case came only a few days back, where in which there was a lot of comminuted fracture. I knew it is a pathological fracture, but I wasn't sure whether it is just a simple bone cyst or whether it is something else. So again, I saw the second picture is a T2 weighted images. Here again, there was a lot of hemorrhage within the cyst, within the lesion. So I was not sure whether it is a cystic lesion or not. Then I had to give contrast. When I gave contrast, there was no enhancement at all within the cyst. So this indicates that it is a simple bone cyst. So this is osteochondroma. Again, you have to follow osteochondroma looking at the nice hyperintense cartilage cap here. And one more important thing of MRI is the skip lesion. So you have a large osteosarcoma in metadiaphyseal area, but you have a skip lesion in the diaphysis as well. So this is very important role of MRI. Lastly, we have to look out for other no-touch lesions and tumor mimics, like stress fracture. Here you can see a linear stress fracture. MRI is again helpful. Osteopyclosis, myositis ossificans, which we already saw. This is another example of myositis ossificans, where we can see nice rim of calcification, even though MRI is showing extensive edema. This is a bone infarct where they have sharp borders as compared to enchondromas. Langerhans cell histiocytosis, brown tumors where you can see lots of bone destruction. There are a lot of multiple lesions and cortical tunneling and all those features which you see in hyperparathyroidism, nephrolithiasis, and erosion of the distal clavicle. So all these things has to be kept in mind before doing any interventions. So my take-home points are like you have to have a clinical details and lab parameters should be available all the time. And radiographs are the key for bone tumor evaluation. And do not read MRI without the radiograph. CT and MRI play a major role in staging and surgical planning. And biopsy has to be done only if surgery is planned in the same institution. And skin track the biopsy should be included in the surgical phase to avoid seedings and post-surgical recurrence. Always you should be aware of tumor mimics in order to avoid unnecessary interventions. Thank you.
Thank you, Pushpa. That was quite exhaustive and very interesting. I think we went through the entire gamut of the bone tumors, and that should have been a really interesting for us. So we'll now go on to the next topic, and then we will have Venkatadass following this. So how to read plain X-rays of the thoracolumbar spine. Now, as I told in the introduction, a clinician is only as strong as his diagnosis. And for this, we go through these following steps: history, clinical examination, plain X-rays, and advanced imaging. Unfortunately, in these present days, when diagnostic radiology is moving into high technology, there is a lot of emphasis on MRI, PET scans, CT scans, and DTIs. And radiologists are still most concerned with cross-sectional imaging, most of them. Neurologists and neurosurgeons usually do not even order a plain X-rays. And so the question is plain radiology still relevant in spine? Let me show this example. Now, this is a 36-year-old female who has a definite indication for a surgery for L4-5 disc. And the plain X-rays look normal. But when we do a flesh and stress X-rays, you can very clearly see that there is a instability over here. If this was missed and surgery was done only by doing MRI, then the results would have been disastrous. Also, in many of these cases where whether it may be a deformity or whether it is extensive spondyloelectric issues, what you do to manage, what level you will intervene, and how do you look at progress completely depends upon plain X-rays. So X-rays are informative to a great extent. Only sadly, the art of reading plain X-rays are often forgotten. So when we say X-rays are not important, probably we mean to the eyes do not see what the mind does not know. It is also important to know that a good orthopedic surgeon needs to be his own radiologist, at least as far as the plain X-rays are concerned, because we use them so often, and it is impossible to wait for a radiologist's report in every one of these cases. So it is quite important that we should have a good knowledge of good X-rays. If you are going to depend a lot on X-rays, then we should make sure that you have a good X-ray. I would like to emphasize this to every one of the junior surgeons, because often we see big disasters happening because of poor X-rays. And in this, we need good exposure, adequate covering of the region, and position of the X-rays. Now look at here. If you look at an X-ray like the one that you see on your left, it's obvious it is bad. What is in the center may be acceptable for lots of us, but you need to ensure that in your institution, all your x-rays are what you see as what you see on your right. Now, most of us would not accept this x-rays. Most of us would accept this, but you need to actually accept only the right one, because otherwise you will miss the disc degeneration over in the L5S1, listhesis of grade 1 in L4-5, and also an ossification of the disc and PLL at a higher level. Now, all these are very, very important. Now, the exposure depends upon your BMI, and obviously your exposure needs to be different for somebody with a greater BMI. It depends upon bone density. And so you need to have a trained radiographer who will individualize it for the patient. The second obvious thing is most important is that adequate covering of the region. If you look at an AP and the lateral view of the lumbar spine, this is exactly what you must be seeing. The X-ray should cover from T11 to coccyx in the spine. The sacrum and the sacroiliac joint and the ilium and the pelvis must be nicely seen, and also both the hip joints. If you do not have this adequate exposure, you can get into a lot of problems. For example, the one on your left looks good for the lumbar spine, but if you miss the lumbosacral spine, then obviously a small listhesis may be missed. Now, this was a patient, an elderly patient, who was actually being treated for degenerative scoliosis and back pain and gluteal pain for a long period of time. But when an adequate exposure is done, you can see that there is also a problem in both hips, which can actually be the cause for the pain. So make sure that you have an adequate X-ray which covers the entire region of interest. If you do not cover the hips, if you do not cover the sacroiliac joint, you can miss early ankylosing spondylitis, changes in the SI joint, and sometimes even big disasters can happen because you miss tumors in the ilium or in the pubis or in the close by regions. The third important thing that before you will accept an X-ray is make sure that the patient's position has been correct as per the beam. Now you can see it is of the same patient. When there is a small rotation of the beam or the patient lying with a small rotation, you can see that you do not see the L5S1 junction adequately. The disc space is not seen. A small vacuum sign is missed in the picture, and also a lysis which is seen on the right film is not seen on the left film. So a good exposure, adequate covering of the region, and positioning of the patient are all important. When you do not see any of these, the question then comes, would you accept an X-ray which is of poor quality or not? Now, it might be sometimes embarrassing to ask the patient to go again for an X-ray, but we have to understand that a misdiagnosis or a wrong diagnosis is costlier than repeating an X-ray. And when you do that, it might even undermine the confidence that the patient has on you. So don't hesitate till you have a good X-ray. Now, the next temptation for most of us is to look at the lateral view of the spine first than the AP view. But you should always start with an AP view, because you will understand over a period of time with experience, AP view gives tremendous amount of information with which you can look at things in the lateral view much better. All these things need to be seen, and they have to be seen in a very correct and disciplined manner. And of course, the first one is the alignment. Alignment you look at by having an imaginary line, a central line which passes through the spinous process. And any deviation from this, you will know that the alignment is wrong. You can also look at the alignment by drawing a line on the lateral walls of all the vertebrae. And the normal alignment of these lateral lines is that is of an inverted funnel. Now, if this is not true, you can see that when you draw the lines, you can see that it is out of alignment. Now, this alignment may be out at one region, and it may be an angular alignment loss, or the angle can be because of a congenital reason like a wedged vertebra, or it might be a globular loss of alignment. And all these gives a clue because all these represent different pathologies, and you can understand what is happening better. When you're talking about alignment, not only angulation is important, but also translation is very important. Now, you can see here that there is a translation loss of alignment. And even in this scoliosis, it's important to know that between L3 and L4, you have a loss of alignment in the way of translation also. Because each of these vertebral bodies are placed on each other. More than angulation, it is translation that will cause dural compression. And so you have to look at it very carefully. The alignment is next to look at is the pedicular alignment. As I mentioned before, the normal is to have an inverted funnel appearance. If you have both these lines straight, then it means that there is a congenital stenosis. And in achondroplasia, you have an opposite where there is a vertical funnel shape. And these are usually associated with a tremendous amount of congenital stenosis. We then have to identify each of the anatomical structure, and the picture gives actually a clue. Now, of course, the body is very important, but the next important anatomical structure are the pedicles. And you can see that it has been likened to two eyes of the owl, and the spinous process, which is much lower down in relationship to the pedicle, almost gives the appearance of the beak of an owl, and these are the two ears of the owl. So this, you can see that this is the picture that comes to your mind, and this is the analogy that has been described. And this is quite useful because you can have a systematic way in which you can look at each of the vertebrae quickly and make sure that there is no destruction over here. Loss of a pedicle, as you can see over here, always denotes a destructive lesion. It looks like a winking owl, and it is often due to a metastasis. Now, when you look at these pedicles, it is not just the destruction, but even if one of the pedicles are looking more sclerosed than the other, then also it is very important because it is indicative of the possibility of a sclerotic metastasis. Once you have looked at the pedicles, you also carefully look at the interpedicular distance. If you have splaying of the pedicles in one of the levels in a trauma patient, it is very indicative of a burst fracture. In non-trauma situations also, interpedicular distance splaying or increased interpedicular distance is very important because it indicates myelodysplasia. In a patient in whom there is a myelodysplasia appearance with increased interpedicular distance, carefully look for the presence of a bony spur in between, because that is indicative of a bony diastema. And these patients need to be carefully looked at and managed properly. If there is a fracture through the pedicle, then of course it means it's a chance fracture. So once you have observed the pedicles and the changes in them, you have to look at the spinous process. Now, the spinous process is a very good indicator for loss of alignment. So you carefully look at the spinous process, and also if there is a congenital anomaly of a spina bifida. A spina bifida by itself is innocuous. It can be an incidental finding, but many of these patients also have facet tropism. So a spina bifida does not cause back pain, but the facet tropism or a pars intra-articularis rupture that it can be associated with can be a cause of back pain. So when you note a spina bifida, you should carefully look for these changes in your lateral view. Now, if there is a destruction of the spinous process as you see in this patient, then again, it means that there is a destructive lesion, and this is called the beakless owl sign. So the spinous process is the next one that you must actually look into it. Lastly, of these three posterior appendages, the transverse process. And when you see a fracture, it definitely indicates a significant injury. Especially if you have a fracture of the transverse process in more than one, it is indicate of a severe abdominal injury. And if there is a fracture of the transverse process along with the sacroiliac joint injury, it indicates a spinopelvic disruption, and that is a very major injury. After you have looked at the posterior appendages, the next thing is to carefully look at the lumbosacral junction, because this is the area which is very high in incidence of congenital malformations. If you have to carefully look at the lumbosacral junction, you really need to look at the Ferguson view, which is where the beam is directed at 30 degrees scaphalic, so that this part is very clearly seen, as you can see over here. Now, this shows on the left the normal picture that is taken, and on the right, you actually see the Ferguson view. So you can really clearly see the huge transverse process of L5, the pseudo-arthrosis over here. You can see all the sacral foramen very clearly. You can see the sacroiliac joint very clearly. So the Ferguson view is something that you should do to look at the transitional vertebra. Be careful when you talk about the numbering of the vertebra. Make sure that to rule out a sacralization or identify whether there is a lumbarization of S1, because it has its own clinical implications. Now, any of these transitional vertebra, there are many different types, and we go by the Castelli classification. I'm not going deep into it, but there are 4 different types. And this is very important because they can be associated with Bertolotti syndrome, where because of the pseudo-articulation, there could be a bursa formation. And these bursa formation can also give rise to the far out syndrome, where it can irritate a nerve root. So the clinical significance of a transitional vertebra is that there can be increased incidence of low back pain. It can be a part of a Bertolotti syndrome. It can be a part of far out syndrome. And for a surgeon, if you are not identified it properly, there is also the increased chance of wrong level surgery. So look at the spina bifida, and next to that is the sacroiliac joint. You see, there are so many things to see in the AP view. And I have seen many of the young surgeons just look at the AP view for just a glance view and then take it off. Now, sacroiliac joint, the sacroiliac arthritis or fusion of the joints can be the first indicator of spondyloarthritis, ankylosing spondylitis. And the other thing that you should commonly note is the presence of osteitis condensus ileus. Now, why this is important? Because you should not associate it with ankylosing spondylitis. You should not associate it with a tumor. You should not think it is inflammatory or infective. How you differentiate it is always a triangular dense sclerosis at the lower part of the sacroiliac joint. It is usually bilateral, and it is more on the iliac side, and it is not associated with any problem. So make sure that you always look at lack of sacral involvement or joint space narrowing is considered to be diagnostic of this condition. So once you have looked at this and also made sure that the hip joints are normal, you then start looking at the lateral view. So it's very difficult to number the vertebra in the lateral view. So you already must know about lumbarization or sacralization or the presence of a transitional vertebra in the AP view before you start looking at the lateral view. You again look at the alignment and the posterior column. And also, this is the only time that you can have a good assessment of sacrum and coccyx. So a picture like this is not adequate. And you must have exposure like this where the sacrum and the coccyx are very clearly seen. So this is all very important. Otherwise, 1 in 1,000 cases, you will miss a diagnosis. So you again look at the alignment. and you should have a normal lumbar lordosis. Now, you also should know that this lordosis is contributed to a great extent by the lower two levels. L4-5 and L5-S1 are the levels which contribute maximally to the lordosis. If you have the lumbar lordosis obliterated, it is indicative of early spondyloarthritis or a disc lesion with severe paraspinal spasm, which leads to this condition. A reversal of this arch is called kyphosis, and also you can also look for, this is the time that you have to look for whether there is listhesis over here. When you're looking at the lateral view, you look carefully at the vertebral body and the disc, and not only just at them in isolation, but two vertebral bodies and the disc and the facet joint is called the functional unit. So alterations of this is not only going to give you an idea of the anatomical change and the morphological change, but it also gives you an indication of the change in function. An alteration in the functional unit, and this is very important. The foremost important thing is that we need to look at disc degeneration. Now, there are two levels over here where there is a normal disc between L3 and L4, where you find there is a good disc space. The end plates are normal, they are convex in shape, and there is no irregularity over here, and there is no major osteophytes in L3. In contrast to that, if you look at the joint between the disc between L4 and L5, it carries all the radiological features in plain X-ray of a disc degeneration, a severe disc degeneration. There is considerable loss of disc space. There is a local kyphosis at that level. The end plates have become thick, sclerosed, and also irregular. There are very prominent osteophytes. There is a retrolisthesis of L4 over L5, and this is a characteristic feature of disc degeneration. And also in the disc space, you can faintly see there is a gas shadow, what we call as the vacuum phenomenon, or it goes by the sign called Knudsen sign. And because of the collapse, the two vertebral bodies coming close to each other, you are also having a compromise of the foramen. Now, whenever you have a loss of disc space, be careful to immediately look at the end plate. Now, if you have an end plate which is not sclerosed, which is lytic, you can see some destructive elements going on there. Infection must be a good first diagnosis, whereas disc degeneration is always involved with sclerosis. When you have a disc degeneration at one levels, always look at the entire spine, because disc degeneration has 66% influence of genetics. And so a disc degeneration at one level always has a multiple level problem. Here you can see there is a lack of alignment. You can see that there is a vacuum shadow in multiple levels, a lot of osteophytes and a loss of alignment over here, and this is very important. Now, Kirkcaldy-Willis actually has put on the 3 stages of the disc disease, where it goes for dysfunction, instability, and restabilization. And here you can see that is exactly what is happening over here. At L3 and L4, it is in the stage of dysfunction. You can see that there is a lateralisthesis, there is instability, and there is a traction spur. These are 3 important signs of instability. So these patients will always have back pain when they have. But at a lower level, you can see it has gone on to the last stage of restabilization by complete collapse and also a large amount of traction spur. So these are the 2 things, and you will find that in patients, they have, same patient can have it in multiple levels. A traction spur is one which is not at the border. It is always about 2 or 3 millimeters above the margin, and it is horizontal, and it is not a sharp ended one. Whereas the claw or the is always pointing upwards or downwards, and it's very huge, fully ossified, and it is always starting from the margin. Now, when you look at the disc, One of the other things is you should look at whether there is a calcification of the disc. When there is a complete loss, when there is a multi-level degeneration of the disc, if you find a calcification like this, it denotes ochronosis. And you can always confirm ochronosis by the presence of sacroiliac joint changes and also extensive arthritis in the hip joint. When you have these two findings, I have found many of the students confusing ochronosis and ankylosing spondylitis, and that's the reason I have put both of these here. Ankylosing spondylitis is distinct in the fact that very rarely you will have a decrease in disc space. The disc space is usually very well maintained. And you will also find that the end plates are very normal. They are not irregular. They are not destroyed. And they are always seen very prominently. And the calcification and ossification is on the anterior longitudinal ligament, and the facet joint is always involved. This is completely different to ochronosis, where the disc space are completely reduced. Bone is always seen on bone, and whatever is left of the disc space is calcified, and the facet joints are not so much changed. So once you have looked at the disc space, the next thing is to look at the vertebral body. You look carefully at the borders and also the texture. You should have a good quality picture here, because although you can see on the right, you know that something is happening on the body. If you have poor quality X-rays, sometimes the lytic lesions in the body and change in the texture you can often miss. There are very distinct changes in the vertebral body, which is very diagnostic. Now, osteoporosis, Paget's disease, prostate metastasis, and fluorosis, they are all increased with sclerosis of the vertebral body of different patterns, as you can see over here. And they all have good diagnostic capacity. Now, there are certain metabolic conditions also which give distinctive patterns. Osteoporosis is one, because the body is very weak, the disc is still maintained, and the discal pressure causes multiple small fractures of the end plate, which actually leads to ballooning of the disc space, and the appearance is that of a codfish vertebra. The next important is the rugged Jersey spine, which is seen in renal osteodystrophy. And once you see this characteristic pattern, it always stays in your mind. Picture frame vertebra is very characteristic of Paget's disease. You can see that apart from the picture frame appearance, you can also see that this vertebral body has become larger, both in the AP view, and if you see on the lateral view also, it will be large. And sclerotic metastasis is another picture. So all these very characteristic, distinctive radiological patterns must always be saved in your memory, so that when you see next patients like this, then you will always remember this. When you have osteoporosis and when you have an osteoporotic fracture, yes, stress X-ray is very important, because then you will have the alligator sign positive. You can see that in the flexion view, the two cortices are coming close, but when you try to extend, you find that they are opening up what is called the alligator sign. Now, once you have seen the texture of the bone, then you look at the borders. And if you have anterior scalloping, and if this scalloping is over multiple bones, as you can see over here, then it is indicative of an aneurysm or a long-standing prevertebral abscess. Similarly, a scalloping on the back is more associated with tumors or neurofibroma, and in a developmental condition of this achondroplasia. But it is usually more common in a tumor, and you must be careful. Vertebral body peaking, if it is central anterior wedging and posterior scalloping, again, as we told, it's achondroplasia. Spondyloepiphyseal dysplasias and Hewlett's syndrome and Marquez disease, they all have anterior peaking, and these are all very diagnostic. Once you have seen and cleared the vertebral body, you need to look at the posterior column, and this is the pedicle, the pars, and the posterior spinous process, and the facet joint. Now, pedicles are more easily assessed in the AP view, but a short, stubby pedicle, a bulky one, is very indicative of spinal canal stenosis. We talk of the Pavlov's ratio or the Togg's ratio, where the ratio between the body and the posterior structures, if it is less than 0.8, it indicates significant pedicule. If you have a doubt, then you must return back to your AP view. And if you have a narrow interlaminar area, if you have sagittalized facets. So in the AP view, normally the facets are not very clearly seen because they are more coronarly oriented. When the facets are sagittally oriented, then it is indicative of canal stenosis. And also, if you have a narrow interpedicular distance and these two lines are parallel, then it confirms that there is a problem. The next structure to look at is pars intraarticularis, and that is indicative of listhesis. And these defects are very clearly seen whenever there is a listhesis. The defect is very obvious. But wherever the defect is not obvious and clinically you suspect, then you have to do an oblique view. And this is the very characteristic Scott Terrier sign, where you can see that there is a defect over here. Now, the snout of the terrier is the transverse process. The superior articular process represents the ears, and the inferior articular process represents the foreleg, and the lamina represents the body. Now, once you have seen here, the pedicle is seen, the bullseye view is seen as the eyes. Now, this is necessary, but if you have a doubt, you should go in for advanced imaging over there. When you see a high-grade listhesis, then there are associated features which you see over here. A beam which is coming from the front in the AP view, actually you can look at the lowermost vertebra. You can see the end-on view, and this gives the appearance of the inverted Napoleon hat in the Ferguson's view. A larger listhesis, which we call as spondyloptosis, is always associated with a very prominent Napoleon hat view, and it also always has a big sacral dome, a dysplastic posterior element, a vertical sacrum, and a trapezoidal L5. So these are all the features which indicates that these lesions are quite positive and it will progress. Lastly, lateral views are not complete without stress views for instability. Now you can see here the extension view looks good except for the vacuum signs, but a flexion view very clearly shows that there is a translation and also a rotation, which means that there is a problem. Dynamic instability in disc prolapse is so commonly missed because people are looking at MRI and not looking at a stress view. And if you're practicing in an institution, you must make it a dictum that all lateral views of the lumbar spine will be done with neutral, flexion, and extension, because that's very, very critical. Same, if you're looking at the post-disc surgery pain, unless you do a stress X-ray, you will not be able to identify what is the extent of instability. Now, before I close, I would like to talk about some specific conditions, and I'll just hurry through this because sacroiliitis, yearly you can see that it is very fluffy, irregular. There will be increase in widening of the sacroiliac joint, more changes on the ilium side, and then at late stage you can see that it is completely fused. That is easy to diagnose, but in the early stages you should look for two signs. Because they are enthesopathies and there is a lot of inflammation at the place where the ligament joins the bone in the corners, you will find some small erosions, and that is called the Romanus lesion. Or later you can find that they become sclerosed and looks more prominent, and they are called the shiny corner signs. The other early sign in ankylosing spondylitis is that what is called the squaring of the vertebra. Normally, the lumbar vertebrae, they are concave on the anterior margin. And because of the deposition of the calcium over here, you can see that these vertebrae became completely squared. And these are very early signs. Whenever you have calcification, to differentiate it from dish, you will find that there is no extra bone formation and the calcification is vertical and it is along the lines of the ALL, and there is a fusion of the facet joints. Whereas when you talk of dish, you will find it is completely opposite. There is extensively a lot of new bone formation formed beyond the confines of the vertebral body, and you can find that these are almost like claws coming up and above and fusing with each other. So you will also find that this extensive ossification is also in ischial tuberosity and the iliac crest, and that will give you a very good clue that it is different. Lastly, infections. I'm not going into deep because that's a separate topic by itself. Most of these infections start in the disc space, and you can see that it is a paradiscal infiltration with loss of end plates, and at a later stage, more of the vertebral body is lost and a lot of kyphosis takes place. And at a more extensive stage, you will find that there is a complete collapse. The facet joints open out on the back, and then that is the beginning stage of buckling collapse. Now, when does infection become unstable, and when does it become liable for a buckling collapse? You can easily find by looking for the spine at risk signs. These are 4 signs which are found in plain X-rays. You don't need advanced imaging for this. So facetal separation on the lateral view, posterior retropulsion on the lateral view, a lateral translation on the AP view, and the toppling sign. Now, these 4 signs, if you have more than 2 signs, then you can be sure that there will be a huge increase in deformity, and you have to be careful about these patients and get a spinal stabilization done yearly. Between tuberculosis and brucellosis, there is always a confusion. But in brucellosis, the vertebral body destruction is usually very less. You will find that very little vertebral body destruction takes place. There is a lot of ossification of the ligaments and a proliferant parabeak appearance over here. A lot of sclerosis even during the active stage, which differentiates TB and this. So I have just put off a lot of data, maybe too much of points to be digested in one go. But these presentations, what Dr. Pushpa presented and I have said, they're all going to be on the YouTube. And so you can go back to see the regular features and characteristic radiological appearance. Now, I would like to say this again. If you have to be a good orthopedic surgeon, you need to be your own radiologist, at least for plain X-rays. Having a very good musculoskeletal radiologist is critically important for every orthopedic unit to become complete. But you should know the radiological basis of all the diseases so that you will make a good diagnosis. And also, it's very important that you should know that radiology comes after clinical examination. Whatever the patient gives in your hand, even if they give you the X-ray before they start telling their history, make sure that you do a good history taking and a clinical examination, because X-ray is never a substitute for good history and physical examination. So as they say, see, hear, feel, and then do the investigations, and that will be a good part of clinical radiology also. So as Louis Pasteur said, you need to know what you're looking for. And in the fields of observation, chance favors only the prepared and the learned mind. So thank you very much for this opportunity, Dr. Venkatadass, to start his topic on imaging of the pediatric hip. I mean, that's something not only very crucial to the practice as a whole, but also to postgraduates and young junior surgeons. It's a very important topic, exam wise also. Thank you, Venkatadass, for being here, and over to you.
Thank you, sir. Good evening to all of you. Thank you very much for the opportunity. And I'm going to talk on imaging of the pediatric hip as a whole. And as you know, it's a very extensive topic and it is impossible to cover everything from A to Z of pediatric hip imaging. So I'm going to go with the modalities, various modalities which we use in pediatric hip imaging and how we really choose which modality to choose in particular clinical scenario. And then focus more on reading a normal pelvis X-ray, which is more important in day-to-day practice. And finally wind up with the classical radiological signs and some of the common conditions, pediatric hip disorders, which we see in our day-to-day clinical practice. So the modalities which we use are ultrasound, X-rays, CT scan, and MRI. So we saw that there are different modalities of investigation for the imaging of hip joint, the pediatric hip joint in particular, and one how chooses the right modality depends on three important factors. One is the age of the child. The second is the pathology behind, which we discussed that after a history and clinical examination will come to a working diagnosis. And the third is what specific information the surgeon is looking for in the particular investigation. So with this, I was talking about the clinical scenarios. And we started with this 16-year-old boy who had come to us with pain in the right hip for about 3 months, which was more in the night. And we saw that his X-ray was showing, not showing much of a positive finding. And the CT scan is that where we got exactly stuck. And when you do a CT scan for these patients, when you have osteoid osteoma as a diagnosis in the back of your mind, you'll be able to pick up the nidus very easily with the CT scan. Let us look at the next clinical scenario where we have five-year-old girls, two girls who presented with the similar complaints. Both of them had painless limb. And on clinical exam, the first child is having a restricted abduction with increased rotations, and the child B is having restricted abduction with restriction of internal rotation. So we know that we have a clinical diagnosis with these findings, and the X-ray of the first child shows a dislocated hip on the right side, which is a neglected DDH, whereas on the right side you have a congenital coxa vara, which is classically presents with a restriction of abduction and internal rotation. So in this scenario, for us, we are taking X-rays to confirm the clinical diagnosis which we have already made, and this mode of investigation is more than enough for us to make the clinical decision making as well. Let's move on to the third scenario where we have a 16-year-old athlete. She's an athlete is a state level player, and she has severe pain in the left hip and she's not able to play. It is limiting her activities. Clinical examination is having painful rotation. The terminal rotations are subtly painful, and this is her X-ray. So on a broad look, the X-ray looks normal, though there are certain abnormalities which I'm going to discuss about in the later part of my talk. So in this particular patient, just by X-ray findings, we will not be able to localize the cause for her pain. So in this particular patient, there is a role for MR arthrogram, which shows a labral tear along with the extensive effusion in the joint. With this, we will briefly move on to various modalities. First is the ultrasound. As you know, ultrasound has three important indications as far as the pediatric hip imaging is concerned. One is DDH as a screening tool. It is used in many countries. The second is synovitis, and third is septic arthritis. So DDH for neonates, we discussed that the femoral head is completely cartilaginous, and you need to do an ultrasound to see whether the head is located or not. This is the standard position which we do the ultrasound, which what we call as the lateral position, and the plane is called the coronal plane ultrasound. And that's the kind of image which you get for ultrasound of the hip. So in our practice, we don't have the facility of universal screening of all the newborn babies. So what we follow is called the at-risk screening. So whenever we feel that the child is having a high risk or the newborn is having a high risk for hip dysplasia, we go ahead and do the ultrasound. So interpreting the ultrasound is important. As a clinician, we need to know that. So this is the ultrasound probe, which is in the lateral position. And what you see here is the bony acetabulum, and this is the cartilaginous acetabulum, and this is the labrum. So we need to know the orientation of the ultrasound. That is more important. But we as orthopedic surgeons are always used to see the hip X-ray like this. So as far as the ultrasound is concerned, you got to rotate the image, and exactly the same information is seen in the ultrasound image as well. So you have the femoral head there. The left is the bony ileum, and that's the acetabular cartilage, and that's the labrum. Then you have the gluteus minimus muscle and the gluteus medius muscle. So essentially, this represents the bony acetabular roof, and this part represents the cartilaginous roof. So your alpha angle is drawn with a straight line drop down and the line drawn over the bony ilium. That forms the alpha angle in the graph classification. I'm not going into details of the graph classification, and you have various types in it. But only disadvantage is this particular classification for hip dysplasia based on ultrasound is that this is highly user dependent. So it completely depends upon your sonologist or the radiologist who's doing the ultrasound of the hip joint. So type 2D is considered as decentering, and type 2D, 3 and 4 needs intervention. So one of the easiest way to find out whether the hip is dysplastic or not in ultrasound in a clinical practice is to see the image and you drop a line from the lateral aspect of the acetabulum, that's the bony ilium, down. And if you can see the femoral head, which is end-located, it is important that your section, the ultrasound image, should show all this. There should be a bony ilium visible, there should be the femoral head, and the cartilaginous acetabulum also visible. So in this particular section, if you drop a line, and if you see that there's a femoral head, more than 50% of the head is medial to that line, then you're sure that this hip is very well contained and your acetabulum is not dysplastic. So this is a very simple way of assessing whether the acetabulum is dysplastic or not in the ultrasound image. And the next indication for ultrasound is to find out if there is an effusion in the hip joint. So it can detect an effusion. You can see this is the femoral head margin, which is seen white, and this is the effusion. But unfortunately, you will not be able to differentiate between pus and the synovial fluid. You can do ultrasound guided aspiration to see if there is pus inside the joint. Next, let's move on to the X-rays, which is one of the most common investigation which we do in our day-to-day practice. And practically any pathology which is affecting the hip, X-ray can be used. I'm not going to go to the details of the various conditions which I'll subsequently discuss. The next modality of investigation is the CT scan, which has very limited role as far as the pediatric hip is concerned. So one should be aware of the fact that the CT scan is having a huge amount of radiation, and in pediatric patients, we don't want to have unnecessary CT scans taken. So there are very specific indications for CT scan. One of the conditions is osteoid osteoma, which we saw previously in a patient. And in slip capital femoral epiphysis, when you want to quantify the amount of slip, or when you want to see the status of the physis, you can take a CT scan. And in cases of sequelae of the Perthes disease or septic arthritis of the hip, where you are planning complex reconstructive surgeries like head reduction osteotomies or head reshaping procedures, there is a role for a 3D CT scan. And nowadays, people are doing 3D printing to pre-plan their surgery as well. So these are the limited indications. So just a case example to show a patient with bilateral slip capital femoral epiphysis. You can see that there are slip on both the sides, but with this information, it is difficult to decide what you want to do for this particular patient, because the status of the physis is not known clearly by this X-rays. It is in these patients where CT scan may be indicated. So when you take a CT scan, you'll be able to see that on the right side, the physis is still open, whereas on the left side, the deformity is much more severe. You can see that the neck is bent, and this is called the banana neck deformity, and the physis is almost partly fused. So this helps in making decision for this particular patient. Next is the MRI. MRI again has very specific roles in imaging of the pediatric hip. One is infection. You can see the amount of abscess collection, the extent of the involvement of the osteomyelitis in the proximal femur. And the second thing is where the status of the head of the femur. So we know that septic arthritis causes destruction of the femoral head. And in young children, you'll not be able to make out because a part of it is cartilaginous. So in these situations where you want to know whether the head is there or not, MRI is a good investigation to go ahead and do. And the second common indication is when you are looking for chondrolabral pathologies, particularly in femoracetabular impingement, where you want to see if there is a labral tear or not, or idiopathic chondrolysis, where in early stages you can pick up the disease and you can start the treatment. And advanced MRI imaging like perfusion MRI and digameric MRI are indicated when you have in certain clinical scenarios, which are advanced imaging and mostly used for research purpose and not into clinical practice as yet. So let's look at this again, a clinical scenario of a 12-year-old boy who had a trivial fall 2 months back, and he had a native treatment. And 2 months later, he developed severe pain and he was unable to walk. So this was the X-ray which was looking normal at the time of the fall. Fortunately, they have taken an X-ray at the time of fall and then went for native treatment. And this is the X-ray when he comes to us with severe pain and fever. We know that there is a gross destruction of the entire femur and there is a slip in the proximal femur. So though the X-ray gives a lot of information here, we need more information in this particular patient before go ahead and doing any sort of treatment. So if you take the MRI in this particular patient, you can see that there is a lot of abscess in the lateral and the posterior aspect of the distal femur, as well as the proximal femur. There is a slip and the capital femoral epiphysis was completely avascular, which has a very huge bearing on the treatment of this particular patient. A word about the perfusion MRI, which is widely being used at a research level in Perthes disease. It is a gadolinium enhanced MRI with subtraction technique, and they have a specialized software to measure the amount of perfusion percentage. These are the example images, and based on the color codings, they decide how much of perfusion is happening in the femoral head. So this investigation is being used in early stages of Perthes disease to quantify the amount of femoral head involvement, and they are trying to say whether they can come out with a value, particular value of perfusion at which stage, which can decide a prophylactic containment surgical procedure will be of use to the patient. So this is a case again of a post-septic sequelae. You can see that the right hip is the ossific nucleus is looking small, the femoral head is small, and there is severe coxa vara. Though the X-ray gives a lot of information, we really do not know whether the head is completely present or it is absent, which is important for us to decide the treatment. So when you do an MRI, we'll be able to see that the child has got a huge head. So this information is of very high importance for deciding the treatment, where you can plan to reconstruct the hip joint in this scenario by doing a valgus osteotomy. And this is the arthrogram image of the child, which shows that there is a good femoral head. Let's now move on to imaging of various hip pathologies, that is like pathology specific imaging. First is DDH. We did see about DDH in ultrasound, but again in our country we see a lot of patients in walking age, very few patients in the neonatal stage who are being diagnosed with DDH. So these are the common lines which we need to draw in a child who is presenting with suspected developmental dysplasia of the hip. So a line connecting both the triradiate cartilage is called the Hilgenreiners line. A line drawn on the outer side of the acetabular cartilage margin, the outer part of the sourcil, is called as the Perkins line. So the Hilgenreiners line and Perkins line divides the hip joint into 4 different quadrants. And the metaphysis is usually on the inner and medial quadrant. If it is inner and medial quadrant, we know that the hip is in place. So you can see that in this particular patient, it is on the outer side. Then we have to draw the Shenton's line, which is the inferior border of the superior pubic rami, which is continuous with the inferior border of the neck of the femur. So you can see that the Shenton's arc or the Shenton's line is broken on both the hips, which indicates that there is dislocation of the hip. The other important parameter which we need to measure in pediatric hip with dysplasia or DDH is, this is a follow-up patient of a developmental dysplasia of hip who underwent closed reduction. He had DDH on both the sides. We did closed reduction, and this is a follow-up X-ray, and we have to measure the acetabular index. Acetabular index is measured by drawing the Hilgenreiners line, and another line is drawn from the triradiate cartilage to the outer part of the acetabulum. So you can see that there is increased acetabular index on the left side. The normal angle is 30 degrees. Anything more than 30 degrees is considered to be abnormal, and it warrants a acetabular procedure in form of a acetabuloplasty. So a word about Tony's classification. Tony's classification is used to grade the amount of dysplasia in the hip in young children. So Tony's divides the acetabulum into 4 quadrants by a horizontal line and the vertical line drawn at the outer part. And this is called the Tony's point, which is the center of the ossific nucleus of the femoral head. So this is called as grade 1, which is a normal hip. And if it migrates to the outer quadrant, it is grade 2. If it migrates to the superior border of the acetabulum, it classified it as grade 3. And if it migrates further up, it is called grade 4 Tony's. So it is basically to grade the severity of the dysplasia of the hip joint. So this was a problem there was a problem to use Tony's classification when the ossific nucleus was not present. So IHDA, the International Hip Dysplasia Institute, came out with this own classification. So in this, the Hilgenreines line and Perkins line are drawn, and a 45 degrees angle line is dropped. This is called the H line, and they marked a point which is the center of the metaphysis of the neck, so which is called the H point. So based on the position of the H point in relation to these quadrants, again they graded the dysplasia. This is grade 1, which is normal hip, and when the H point is slightly lateral to the Perkins line but medial to the H line, it is called grade 2. When it migrates there, it is called grade 3, and if it is way up high, it is grade 4, which is a completely dislocated hip. So it is important to know these two classifications, X-ray based classification in DDH. The other thing is the Reimers migration percentage. We all know that in children with cerebral palsy, we do hip surveillance and we periodically keep seeing how the hip is migrating out. So Reimers index is measured by the ratio of the physis. This is the Perkins line. You have to draw a Perkins line and then measure the width of the physis and how much of the physis is outside the Perkins line. So this ratio gives the Reimers migration percentage or the Reimers index. And if this percentage is more than 40%, it is an indication for a surgical intervention in a patient with cerebral palsy. Next is synovitis. Synovitis is one of the most common clinical scenarios which we get in clinical practice, day-to-day practice. Transient synovitis of the hip is one of the common conditions. So you should look for soft tissue shadows. You can see that on the right side, there are more enhanced soft tissue shadows and increased medial joint space compared to the left side. So this is one of the classical signs, which is called the Waldenstrom's sign, which is seen in, which just means that there is effusion in the hip joint. It could be due to any cause. So this could be an early stage of Perthes disease, as it turned out to be in this particular patient. When we followed up, the child developed avascular necrosis of the proximal femur, again, which is again one of the signs is Waldenstrom sign. The second sign in Perthes, early Perthes is crescent sign. In the frog leg lateral view, you see a subchondral fracture line. So this is called the crescent sign, which is particular to Perthes disease. So as students, it is important to know this classification, which is called modified Waldenstrom's staging for Perthes disease, which describes the natural history of Perthes disease. So it divides into 4 stages. Stage of avascular necrosis is 1, fragmentation is 2, reconstitution is 3, and remodeling is 4. Each stage is subsequently divided into 2A and B based on the radiographic finding. So in 1A, the height of the capital femoral epiphysis is maintained, whereas in 1B, there is subtle flattening of the femoral epiphysis. So 2 is fragmentation. In 2A, you have only 1 or 2 fissures, which means that there will be either 2 or 3 fragments. In 2B, you have more fragments. In 3A, the reconstitution starts on the lateral 1/3. The lateral aspect alone is reconstitution is happening. In 3B, it comes to the medial side, and stage 4 is the heel stage. So this is the natural history classification or the staging, which is useful in clinical decision making, and it can be asked for exams also. So this is both for clinical decision making as well as in your exams. When it comes to healed Perthes disease, this is also again one of the common scenarios which we get, a child presenting with a painless limb. So these are all the possibilities which you can see. One is coxa magna, which just means that the head is enlarged. The coxa breva means that there is shortening of the neck. And coxa plana just means that flattening of the head. And coxa irregularis is the head is irregular. So it is important to know all these terminologies. And when you're reading the hip X-ray, it is better to use these terminologies. And sagging rope sign again is one of the signs which you see in healed Perthes disease. I'm going to show examples for each of this. So in the left extreme, you can see that the head is irregular. This is called coxa irregularis. This is just a coxa magna. So you see the mushroom-shaped head in this patient. So the right side is the shortening of the neck. It is called coxa breva or coxa brevis. And you can see the sagging rope sign, which just means that it is a shadow of the overhanging head. So this, when you have a huge head, the border of the head is seen here, which is called as the sagging rope sign. Slip capital femoral epiphysis, again, it's one of the common conditions which is very commonly missed in the early stages. So this is an X-ray of a child with an early slip. So on a brief view, the X-ray will look like it is normal. So one can easily miss the slip. So these are all the common signs which is seen in early slip. So all the signs are there in this particular patient. So the first sign which you should look is there is widening of the physis. Compared to the right side, you can see that there is widening of the physis. Definitely this is abnormal. So Klein's line is nothing but a line, a straight line drawn along the superior border of the neck. This line is called Klein's line, and it is normally it will cut at least 25% of the capital femoral epiphysis. On the left side, you can see that it is much lesser. So this sign is called the Trethovan's sign. So the line is called Klein's line and the sign is called Trethovan's sign. Capinus sign is nothing but in a normal hip, if you see the metaphysis of the neck, it overlaps over the posterior wall of the acetabulum, and you see this triangular shadow which is called the Capinus triangle. When there is a slip, that is obliterated. So the loss of Capinus triangle is also called as Capinus sign or the Shams sign. Both are same. The next sign is Steele's metaphysal Blanche sign. So when there is a slip, the capital femoral epiphysis slips posteriorly, and you can see the shadow of the head overlapping the neck in a crescent form. So this crescent shaped overlap of the head is called the Steele's sign or the Steele's metaphysal Blanche sign. So these are the early signs one needs to keep in mind to diagnose an early slip. So next, coming on to the FAI and dysplasia spectrum. FAI is femoroacetabular impingement, and dysplasia is considered as either ends of a same spectrum of disorders. So it is important to get a true AP pelvis. I'm going to tell in detail about how to get a true AP pelvis and what are all the various views which we get and what are all the important things which you should look when you look at the normal pelvis X-ray. So this is a very good article for you to read, a systematic approach to the plain radiographic evaluation of young adult hip, which was published in JBJS in 2008. So those of who are interested in learning the radiology of hip joint, please go through this article in detail. So a true AP pelvis is occurred with the feet in 15 degrees of internal rotation, and the beam should be centered over the symphysis pubis, and the exposure should be adequate to show both the acetabular walls well. So this is how you take the normal AP X-ray. So it's about 120 centimeters. The cassette is placed 15 degrees of internal rotation, and the beam is centered over the symphysis pubis. So this is how a normal AP, a good normal true AP view will look like this. So you have to see first the rotation, if there is any rotation of the pelvis. You can see that the spine is centered to the pubic symphysis, which means that the pelvis is not rotated. And the other thing to look at is the operator foramina, which should be symmetrical on both the sides. The second thing is the distance from the tip of the coccyx to the symphysis pubis, which is normally around 2 to 4 centimeters. So if it is increased or decreased, then it indicates that there is an inlet or outlet view. So it is important to see all these things when you read a pelvis X-ray. Other views, the cross-table lateral view is taken, is a standard lateral view which we take. And this is the X-ray which you get when you take a cross-table lateral view with 45 degrees of angulation of the cassette. The problem with this particular view is there can be overlap of the soft tissue shadows and you get very little information, and this is not routinely indicated for FAI. Then the next view is 45 degrees Dunn's view, which is taken with the affected hip in 45 degrees of flexion with 20 degrees of abduction and neutral rotation. So this is one of the most important views which we need to take when you're doing assessment of the young adult hip for femoroacetabular impingement. So this is the 45 degrees Dunn view, where you will be able to see the femoral head neck junction very well. The next view is the frog-leg lateral view, which is the normal frog-leg lateral view. Again, it gives a very good profile, lateral profile of the proximal femur. And this is a false profile view when you want to see the anterior coverage of the femoral head. So the pelvis is outward rotated 65 degrees, and then this film is shot from here. You get this is a view which you get when you do this false profile view, which is also called as the Liquisnes view. And you can see the anterior coverage of the femoral head. So these are all the various views which is indicated when you are imaging a young or a skeletally mature hip for workup of hip preservation procedures. So now coming back to the true AP view, what are all the things which you need to look when you see a true AP view? First is the orientation and tilt. As we discussed earlier, we have to see whether the spine is centered to the pubic symphysis, whether the operator foramina are good. I will show examples of inlet and outlet in my subsequent slides. The next thing which you look at is the joint space. So you have to see whether the joint space is looking symmetrical on both the sides, or if there is any increase or decrease in joint space. The third thing is acetabulum. By acetabulum, we mean that we have to see how much is the coverage of the hip joint. Next is the femoral head and neck along with the proximal femur. And no reading of the hip X-ray is complete without commenting on the sacroiliac joints and the sacrum and the soft tissue shadows. So you should have a systematic way of reading the X-ray. Whenever a pelvis X-ray is put up, you should go in a systematic way, and you see all these things, you will not be missing anything. Coming to the acetabulum, these are all the things which you should see in acetabulum. The sourcil, you have to see the size of the sourcil, shape of the sourcil, the inclination, the anterior wall, and the posterior wall. So I'm going to show in this X-ray of this particular patient. So this is called the iliopectineal line, which is the representation of the anterior column, and this is the ilioischial line or the colus line, which is the representation of the posterior column. This is actually the sourcil or the eyebrows, which is the weight-bearing dome of the acetabulum. And I'm tracing the anterior wall. In this particular patient, you can see that this is the anterior wall and that is the posterior wall. I have labeled the anterior wall in yellow and the posterior wall in blue. So you should be able to trace both these walls. So it is important to see all this in any pelvis X-ray, and that is the teardrop. So you can see that this is the medial wall of the acetabulum and this is the colus line. So when the medial wall of the acetabulum goes medial to the ilioischial line, that is called as coxa profunda, and if the femoral head goes medial to the ilioischial line, it is called as protrusio acetabuli. So it is important to differentiate between coxa profunda and protrusio acetabuli. The other measurements which we do in a pelvis X-ray is the lateral central edge angle, which is nothing but a line from the center of the femoral head, which is a vertical line, and a line connecting the outer border of the sourcil. So this is called the lateral central edge angle, which is normally around 25 to 35 degrees. An increase in the lateral central edge angle indicates that there is dysplasia, and the decrease indicates that there is a over coverage. The other angle is the medial central edge angle, which is again a line from the center of the femoral head to the medial border of the sourcil. So this is called the medial central edge angle, and it is normally 35 to 45 degrees. So you can see that this is the normal sourcil, which covers the sourcil arc is about 60 to 65 degrees. So we call it that as acetabular arc. The next angle is the Sharp's angle, a line connecting both the teardrops and another line which is connecting from the teardrop to the outer border of the acetabulum, that is called Sharp's angle, which is normal is 35 to 45 degrees. So all these angles are important to quantify the amount of dysplasia versus over coverage. An ideal acetabulum should have at least 80% of the head to be covered superiorly. The posterior wall should be covering 50% of the head, and the anterior wall should be covering at least 20% of the head. It should be anteverted 15 to 20 degrees. And the sourcil size should be at least having an acetabular arc of 60 to 65 degrees, as we saw in the previous X-ray. And the sourcil angle, which is also called as the Tony's angle, it should be up about 0 to 10 degrees. So any angle more than 10 degrees indicates it's an upsloping sourcil, which is dysplasia, and the negative sourcil angle, which is indicative of over coverage. So let us look at some of the other X-rays. So you can see that this is also looking like an AP X-ray of the pelvis. But if you look carefully, the operator foramen is not symmetrical. Definitely there is a rotational problem. It looks like it is right rotated. This is the center of the pelvis. It is not centered towards this. And whenever there is an inlet view, you have to understand that you will have an anterior wall will be over coverage will be seen. So there is a rotation of the pelvis which makes us assume that there is an anterior over coverage. So you should do the calculation in your brain that this is an inlet view, that the patient is not having a true anterior over coverage, but it appears that there is a anterior over coverage, which we call as an apparent anterior over coverage. You can see that the ischial spine signs, which is an indication of a acetabular retroversion is seen. So if you think that this patient is having acetabular retroversion, it is purely because of the position of the pelvis and not the acetabulum is as such retroverted. This is an example of an outlet view where you can see that again, there is increased posterior coverage and decreased anterior coverage purely because of the placement of your X-ray beam. So there is decreased anterior wall and increased posterior wall in an outlet view. So you should, whenever you are reading an X-ray, it is important to see whether your rotation of the pelvis is good, your tilt of the pelvis is good, because all this has got bearing on whether this particular patient is having either dysplasia or overcoverage. It is just not by seeing the X-ray. And this is a good X-ray to show that the medial wall of the acetabulum is medial to the ilioischial line, which is called the coxa profunda. So this is an X-ray of a patient. I'm just going to draw the lines for you. So that is the anterior wall. There is a posterior wall. And you can see that it is covering about 20 to 25% of the anterior wall is covering 20% of the femoral head, and about close to 50% of the posterior wall is covering 50% of the femoral head. And this is considered to be a normal hip. You have a good acetabular sourcil, which is angle about 60 degrees or more. On the contrary, if you look at this X-ray, again, if the hip looks well contained, there is no subluxation. Your source, if you draw the Shenton's line, it will be intact. But when you specifically look for anterior wall and the posterior wall, you can see that though the anterior wall has got good coverage up to 20%, the posterior wall is covering only less than 50% of the femoral head, and your lateral coverage also is less, which is measured by your lateral central edge angle. So that's the center of the femoral head, and your lateral central edge angle is definitely decreased. So this is definitely a case of dysplasia. So mind you that these are all only morphological abnormalities. So when it comes to clinical decision making, we don't just see the X-rays and decide that this patient is having acetabular dysplasia and needs surgery. So the morphology does not mean anything. So the patient should have corroboratory clinical findings for us to do any kind of intervention. This is X-ray, again, looks pretty normal on just a look of it. But when you draw the lines, you will see that that's the anterior wall and that's the posterior wall. That's the center of the femoral head. You can see that whenever the posterior wall is lateral to the center of the femoral head, this is called the posterior wall sign, which indicates that there is posterior overcoverage. And you can see that the lateral central edge angle is more. So this is again a case of another indication that there is a overcoverage, and you can see that the sourcil is also downsloping. Moving on to femoroacetabular impingement, which is defined as a dynamic conflict between the acetabulum and the femoral head. We saw how to image the acetabulum, and we are going to see how to see the femoral head. What are all the parameters which we should see? So there are three types of femoroacetabular impingements which is described. One is the cam, second is a pincer, and the third is mixed impingement. I'm not going to go to the details of what is cam and pincer. So, but the assessment of the femoral head and neck is usually done with the Dunn view or the frog leg lateral view. And these are the two things which we measure. One is the alpha angle and the second is the head neck offset. So alpha angle is usually measured in the frog leg lateral view or the Dunn's lateral view. You draw a line along the center of the femoral head through the femoral neck, and you have to draw a circle which is circle the femoral head. And the second line is usually drawn at the point where the head is going off from the circle. So this angle is called the alpha angle of Notzili. This was described by Notzili, and anything more than 55 is considered as abnormal. So you can see that in this patient, it is more than 55. You can see this bump here, which is the cam bump, and this patient is femoroacetabular cam type of femoroacetabular impingement. So increase in alpha angle indicates that there is a cam type of femoroacetabular impingement. The second thing is to look for the femoral head neck offset. So again, line through the center of the femoral into the neck. The second line is through the anterior border of the femoral neck, and the third line C is through the anterior border of the femoral head. So these are the three lines you draw, and you have the distance between B and C actually measures the size of the cam impingement. So Normally in asymptomatic hips, it is about 11.6 millimeters. And when you have an impingement or a cam bump, the distance is decreased. And the offset ratio is measured by the ratio of the offset divided by the diameter of the femoral head. So when the ratio is less than 0.17, again, this indicates that there is significant decrease in the femoral head neck offset, and it indicates that there is a cam impingement. So to summarize, as we saw, the age of the child, the pathology which you come into as a working diagnosis based on the detailed history and clinical examination, and what information you need on further imaging basically decides what modality of investigation is needed. And I would say that plain X-ray remains the workhorse as far as the pediatric hip imaging is concerned. Most of the information in, I would say, like 80 to 85% of the patients you'll be able to get with just a plain X-ray. CT scan has a very limited role in specific cases, whereas MRI definitely has an important role in pediatric hip imaging as far as your infections and tumors and hip preservation work is concerned. Thank you.
So thank you, Venkatadass. That was really an excellent lecture. So we will just, before we go on to the question and answer session, so I'll be grateful if all of you are here will spend 30 seconds on giving your feedback. That will be really useful for us to evaluate and also make some changes for our next Ganga Hospital seminar. Now, we'll then go on to the question and answer session. So Venkatadass is still there, so I would start with him. How do you differentiate between a healed and active perthes? And when do you know that a perthes disease has started healing?
As we saw the natural history slides, once we come out of the fragmentation stage, that is when healing starts. So you will see newborn formation on the lateral aspect of the physis. So when you see the patient in a stage 3, it is still healing stage, but still we can say that the reconstitution has started. When there is complete absence of any of the fragments, we call that the disease has completely healed.
Okay. And what are all the various positions of X-rays that you've taken? But I think that question came before you actually started, because you have already explained all the positions that are required over here. Pushpa, you're online?
Yes, sir. Yes, sir.
Okay. There are a few questions for you. One is, how do you differentiate between an infection and tumor?
So, can I share my screen for that?
Sorry?
Can I share my screen, sir, for that?
Yeah, sure, definitely.
Unfortunately, we can't radiologically, I mean, using X-rays, it becomes very difficult because both look like very aggressive lesion. Like it might mimic Ewing sarcoma as well as other aggressive bone lesions. So MRI plays an important role to, even ultrasound plays an important role in certain situations where there is a lot of perosteal collections. Like in this case, where contrast is given, you can see there is nice abscess formation around the bone. This almost tells that it is infection. Here also there is a T1 weighted image, and this is a post-contrast image. This is something called as penumbra sign, where granulation tissue forms around the edge of the abscess, intramedullary abscess. This also indicates that this is definitely infection, not a bone tumor. So MRI and ultrasound helps in certain situations where there is already formation of the perosteal abscess. And in case of subacute cases, in which I showed here, if the penumbra sign is seen in T1 weighted images, that is hyperintensity around the collection, then we can definitely tell this is infection.
Okay. Can you highlight on periosteal reaction in benign tumors? Or is it periosteal reactions are very unique to infections and malignancies?
Unfortunately, infections and malignancies, there is no much difference when it comes to periosteal reaction. Both can show aggressive type of reaction. That's what I was stressing all along my talk, that both can show aggressive type of periosteal reaction. It is difficult to tell which is infection based on the periosteal reaction. Clinical parameters and as I said, MRI might help in most of the situations.
Okay. When do you use contrast in tumors?
Only contrast comes into picture when you have doubt whether it is a cystic lesion, and sometimes when you don't know whether the neurovascular bundle is involved or not. In most of the MSK, including tumors, we don't require to give contrast. It is not absolutely necessary. And sometimes when you are looking for a recurrence of the tumor, and in the post-operative situation where there is a query of infection, such times you require to do contrast. And sometimes we also do dynamic contrast in certain situations where it is difficult to tell whether it is benign versus malignant. But biopsy will always help us. So it is not absolutely necessary in each and every tumor to give contrast.
Okay. So there's a lot of questions on radiology only, because I think that's a gray sign which not formal teaching happens amongst the postgraduates. The next question is also for you. How do you radiologically classify osteosarcoma?
Again, osteosarcomas can be divided into conventional osteosarcoma that already I discussed about conventional osteosarcomas. But here you can see there is a perosteal osteosarcoma and then there is a periosteal osteosarcoma. So this periosteal osteosarcoma comes in the grade of intermediate type of osteosarcoma, and paraosteal osteosarcoma comes in a low grade osteosarcoma, and conventional osteosarcoma is said to be high grade osteosarcoma. Here you can see there is in case of periosteal osteosarcoma, you can see large soft tissue component, and there is invasion into the cortex, and then there is some form of periosteal reaction formation, like a Codman's triangle. So this is likely to be periosteal osteosarcoma, which is of intermediate grade. Whereas in case of paraosteal osteosarcoma, you can see that cortex is will be well preserved, and there will be dense ossification of the soft tissue component. Sometimes we'll be able to see a thin lucency between the tumor and the cortex. That's called as string sign. So that is how you differentiate all three types of osteosarcomas.
Okay, thank you, Pushpa. So for the spine section, we have two questions. I'm going to share screen for this because people have asked on. Can you please explain the spinal address signs in greater detail? Oh, I lost my screen now. Okay. Okay. So the spinal address signs, the basis of it is that we did a 15-year follow-up of children with spinal tuberculosis. And that showed two interesting findings. The first is that deformity progresses even after healing of the tuberculous disease. And in fact, a large number of children, the increase in deformity was after the healing of the active disease had taken place. And then we also found, to our surprise, and that was the first description of that in literature, that many of the children also spontaneously corrected their kyphosis. So then the question arose as to why do some of the children become better by themselves and why some of them keep continuing to progress in deformity? And more importantly, is it possible to identify these children who are going to deteriorate at the time of activity of the disease itself? Because at that period, operating on an active disease is very easy, whereas operating on a healed severe deformity is very difficult and also risky. So we looked at many different things. So clinically, age below 10 years was one of the very high risk factors, but radiologically we found a high correlation to the fact that if there is a facet dislocation, then this amounts to what is biomechanically equivalent to what is called as death of the column. Because the spine is a slender column, it has an anterior column and a posterior column. Tuberculosis has already destroyed the anterior column. And when the facet joint dislocates, then also the only hinge goes. And biomechanically, they call this as death of a column, and catastrophic collapse happens, and many of these children go into buckling collapse. So having identified this, we wanted to identify radiological signs, which would indicate that the facets are subluxing or dislocating. And so these are the 4 signs which we found out. And this was described a long time ago in JBJs. The first sign is actually on the lateral view. If you see very carefully, you can identify dislocation of the facet. So that is the first sign. Now, in patients, you will also see, and this is very common in children, that these facets dislocate sequentially. One facet dislocates, and then the deformity increases by 20-30 degrees. And that puts a lot of strain on the facet above, and that dislocates. And then immediately, then there is an increase in deformity of another 30 degrees, and that dislocates the next facet. So this is a sequential dislocation, and you get a buckling collapse. So you need to look at the facet joints whenever you look at a child with kyphosis. The second sign is posterior retropulsion. So you draw a straight line on the posterior wall of the vertebral body of the first normal vertebra above and the first normal vertebra below. Now, you will find that the vertebral body remnants, which are involved by the disease, having dislocated posterior, which means that the facet joints are dislocated. They are free, loose, free-hanging bodies, and they are dislocating posteriorly. Why this happens has lots of reasons of parallelogram of forces. I'm not going there, but this is the sign. The third sign is the lateral translation. If you draw a line connecting the pedicles on the inferior segment, you will find that it is not cutting the pedicles on the superior segment because the body has translated. And the last sign is toppling sign. The first normal vertebra on the superior segment actually rotates completely and faces down, so that a line drawn from the inferior vertebra cuts it above the middle of the superior body. Now, if you actually look at this, because this is sign is frequently discussed and also asked in the exams, all these actually mean only one thing. They all represent that the facets have dislocated. That means there is a functional loss of the posterior column. The posterior column has not been eaten by tuberculosis, but there is a functional loss of the posterior column because of the facet dislocation. Posterior retropulsion cannot occur without facet joints dislocating. Lateral translation in the AP view cannot occur if both the facets are intact. Toppling of the superior vertebral body cannot occur without facet joint dislocation. So they all mean one and the same. And if any of the 2 signs are positive, then these are indicative that this child is at a high risk of very severe deformity. And it is also an indication that these children must be fused at the earliest possible before there is a disastrous collapse. Now, something that has come out of this very interesting is that these spinal twist signs, although described for spinal tuberculosis, is also true for all pediatric conditions. So it's true for neurofibromatosis, it is true for congenital kyphosis, it is true for achondroplasia. So any of these conditions are all very, very important. So you need to know about this. You need to look for this carefully whenever you see a child with kyphosis. Okay, that is one. So one more question that they have asked is when the disc is avascular and the body is more vascular, why does the disc gets infected? So this is actually the fact that the disc is getting infected is a radiological misnomer. Now, the infection is always in the paradiscal vertebral body. Okay, it's always in the paradiscal vertebral body. And when the end plate gets destroyed and the body becomes very soft and destroyed, the disc actually protrudes or extends into the vertebral body. And so when you take an X-ray, it always looks that the two vertebral bodies are coming close, and at a later stage, then everything becomes granulation tissue and goes. So the first infection is always in the bone, and then it extends into the disc. So that is the second question. The third question is, why are there more secondaries in the proximal bones and not in the distal bones? And this is obviously secondaries are related to vascular spread, and the more vascular it is, the more red marrow you have, the more chances that you have for secondaries. So vertebral spine always has red marrow till the end. Proximal place, iliac bones, sacrum, proximal femur, they are more vascular than the distal part of the tibia, foot or acral bones. So these are the questions that have been asked so far. There are many more smaller questions, but they are not related to the topics that we have discussed today. So I'm not going into it. And also the fact that we are about 40 minutes on extend the time. So if it is okay, then I would like to thank Dr. Venkatadass for his excellent lecture on pediatric hip imaging. Very instructional, very complete. And Dr. Pushpa for this wonderful lecture on bone tumors. Very exhaustive, covered the complete spectrum. And what was most important in the talk is it again emphasized that you need to have a protocol and the way you go about it when you see a lytic lesion on the bone. That is very important. So I would like to thank both of them, and also thank PACE people for organizing this, keeping something interesting going on, keeping something educative during these periods when we are all locked down. And thank you very much to Jansen for arranging this, and also to Dr. Ashok Sham of OrthoTV for also live telecasting. So thank you all. Thank you very much for being here with us. Thank you, Ashok. Thank you, Dipali. Thank you, Neil. And we will see you again in the next Ganga Hospital webinar a few weeks from now, and that will be on a trauma topic. Thank you. So
thank you, sir.
All of you, take care, stay positive, test negative, and make sure that we pass off this very safe. Thank you. Thank you, everyone.
Thank you, sir.